Okay. Good evening, everyone. Welcome to our second live. This is Antigua and Barbuda Holistic Coalition. This evening, we are sharing with you the fundamentals of mental illness, specifically schizophrenia. So, for those who do not know me, my name is Serene Prince. I am a holistic psychotherapist and a child and adolescent expert with over 15 years of experience. Some of you may know me from counseling and consulting with Serene in Antigua and Barbuda or Orchard Blue Counseling Services in the US. I am the owner of Orchard Blue Counseling Services and the owner of Counseling and Consulting with Serene. I am also the founder and president of Holistic Coalition. That's Antigua and Barbuda Holistic Coalition. And so we are designed, and our mission is really to build equity and holistic health in Antigua and Barbuda with an emphasis on mental health. And so what we want to do is that we want to provide psychoeducation to persons in Antigua and Barbuda about mental health as well as other areas of medical health because mental health is medical health. We also want to look at all aspects of one's being, and that would be also education, that would be other physiological health, that would be creativity, athletics, religion, and spirituality. And so we want to integrate all of those things in what we design as Antigua and Barbuda Holistic Coalition by coalitions or collaborating with other organizations and individuals who hold the same mission as ourselves. And the reason why we wanted to do that, because we felt that the only way to, or the best way to improve the access to quality and needed services and information is by collaborating with other organizations where persons currently exist. And so that either one or two organizations are there together to provide services and information to individuals in Antigua and Barbuda who may not have ready access to this information. And so this evening, we are focusing on schizophrenia. And so I've already introduced myself, and I'm going to turn it over to our board of director, Tia Phillip.
Hello, good afternoon, everyone. My name is Tia Phillip. I am a counseling psychologist, currently resident in Antigua and Barbuda, so I'm working here on the ground. And as Serene just mentioned, I am board director of the Antigua Barbuda Holistic Coalition, and I am so happy that you are all here tuning in to learn more about mental health and specifically tonight, learning about schizophrenia.
Yes. And so our guest this evening, who is going to help us deliver psychoeducation on schizophrenia, is no other than Jahnavi Patel. Jahnavi is a second year medical student at American University of Antigua, AUA. She is also the vice president of AUA's, is it Psychiatry Interest Association. Jahnavi, is there anything that I missed? What do you want to share with the viewers this evening?
No, I'm just thankful for all the viewers and their interest in psychiatry, first of all, because I think it's just such a great thing for all of us to be here today. I'm
Yes,
excited.
and we appreciate you being here. And before I get into, or we get into the definition of schizophrenia, I want to share why I wanted to talk about it and provide psychoeducation on schizophrenia. So, you may know that I had begun providing mental health services, psychotherapy in Antigua in late 2021. I've gone back and forth between the US and Antigua. By the way, I am born in the US, but I am the first generation born US. All of my siblings were born in Antigua and Barbuda. And so, in my professional experience, I've seen a range of persons with mental health issues and mental illness, but I did see that there was a significant number of individuals diagnosed with schizophrenia and or who had remarkable symptoms that were indicators that they potentially had schizophrenia. And so I want to support this and share with you a report from the Pan American Health Organization, who reported in their epidemiology of mental health issues in the Caribbean. And they quote, the most long lasting of these disorders is schizophrenia, which has been shown to have an incidence of 2 to 3 per 10,000 persons in the general population. This rate has been fairly consistent across a number of Caribbean countries. The rates are higher in very small islands, perhaps as a result of selective migration. Persons with mental illness are likely to immigrate and more likely to return home if living abroad. This is exemplified by the rate in Dominica, which has been calculated as 11.8 out of 10,000 persons. In general, persons with psychiatric conditions are at risk for decompensation, a decrease in ability to carry on with activities of daily living. I'll also share with you a report from the World Health Organization in their 2009 mental health system in Antigua and Barbuda. And I quote, in 2007, the overwhelming majority of mental ill persons in Antigua and Barbuda carried a diagnosis of schizophrenia and related disorders. The service delivery facilitates do not routinely generate, analyze, and disseminate quantitative data representing a defined list of mental health indicators. There is no nationally published report on the prevalence and burden of mental disorders. And that's important to share because data is really what helps us clinicians with our theories, with the way in which that we engage with individuals in certain regions, even in just a hospital or a clinic. And so in Antigua Barbuda, while there is significant number of persons with schizophrenia, we have to give consideration to the stigma surrounding mental health and those that are willing to come forth to seek treatment and or share that they have a mental health diagnosis. And so schizophrenia, because what you'll learn this evening and the way that it presents itself is very hard to not, it's very hard to hide it, I should say. It's very hard to hide that you have you know, as a mental illness such as schizophrenia, and you'll learn more why. So, moving on to the definition of schizophrenia. And so I kind of skipped over. Oh, I forgot. I have to also share with you what we'll be talking about. So we'll be defining schizophrenia. We'll be sharing with you the criteria and symptoms of schizophrenia, the treatments used in schizophrenia, life with schizophrenia, and we'll also want to hear from you all any questions or comments. But I'll share with the viewers, please don't wait till the end. We want you to put comments in, feedback, questions. We want this to be interactive. Yeah. So moving on from there, also want to give you the disclaimer. This is for psychoeducational purposes only. If you're seeking an assessment, a diagnosis, please contact a physician or a mental health practitioner. So, what is schizophrenia? Schizophrenia is a mental illness that affects how the brain works. Schizophrenia falls under the category of a psychotic disorder. Tia?
Generally, when we look at schizophrenia, we will find persons diagnosed with schizophrenia ranging from ages 18 and older. Now, there are instances where individuals younger than 18 are diagnosed with schizophrenia, but they will be categorized as early onset schizophrenia. Schizophrenia does not discriminate as it pertains to racial backgrounds, ethnicities, and it's been found to be slightly more common in men than women. There's also differences with regard to age of onset. We find that our men are more likely to experience early onset schizophrenia, while our women are more likely to experience mid adulthood onset schizophrenia, and we're talking about ages 30 or 40. John B?
Um, s- yeah, so usually the exact cause is unknown, but research has definitely come a really long way. And then when we think about the causes, we like to put all the risk factors together. So it's like a whole picture, it's not just a specific cause. So I'm going to take you down through like some simple examples. Um, so, for example, let's say you're a teenager and you are hanging out with your friends and you are participating in recreational drugs. But, like, as a teenager, you have schizophrenia in your family, but your friends don't. You are the only one who's at a higher risk of getting schizophrenia later in life, even though you're participating in the same activity. If you're a woman who's trying to um, plan, like you're trying to have a child, obviously planning ahead is very important. So if you have prenatal complications, that is a risk of schizophrenia. Research has also found that if you have a child in winter or spring months, you have a higher that child has a higher chance of schizophrenia. And this the research said that it was usually due to the higher viral load during that time. So that has something to do with something happening in your brain, because schizophrenia is like a brain disorder. And another research that I found for the causes was malnutrition. So they did a research for history, like they looked back into history and they checked areas that had famine, and those areas that had famine had more likelihood of schizophrenia. But now that you know, like, there's so many risk factors, there's so many things to think about, especially genetics. um, how do you recognize it? So we categorize them based on positive symptoms, negative symptoms, cognitive impairment, and then sometimes mood and anxiety is also added onto there. So let's break these down a little bit. Hallucinations. When we think of hallucinations, we basically mean that they think something is real in the world. They're experiencing it, but it's not really there. And we don't realize how much we rely on our senses to be in touch with the world. But schizophrenia, the one that fails them the most is their hearing. And they really do hear things that are not there. Um, they could have full conversations with people. They could, and this can, lead to other problems. Delusions. This is a word that gets used a lot in day-to-day language. Or like, you're so delusional, whatever. We use it as a joke, but for schizophrenic patients, it's a very strong belief system that is not real, and it has like a wide range. So it could be something like, I think the government is looking into me and they're following my every move. And it could be something as simple as, I think my friend means to do me harm, and they really do believe that when the friend is totally innocent. They had nothing to do with it. They just
Yeah.
had that strong belief, right? And you can't really. So it's a really wide range.
And if I can add,
Yeah.
in terms of, oftentimes we would call that persecutory delusions, like persecution, right? So that's where persecutory delusions come in. That sometimes your someone's movement that the delusions will tell them that your movement is to hurt them, even if you're not coming in their direction, their perception, right? Because I use that a lot in documentations, that there seems to be their perceiving or their reality based is not aligning with what is actually happening. And so that's where persons may say as family members that the loved one may have attempted to lunge at them, or may say that they're trying to hurt them, which more times they don't lunge at you. They would more do things to like barricade themselves and protect themselves from you because they believe that you are going to do harm to them, or they tend to be AWOL, and that usually means that they leave the home for a number of days and you don't see them because they feel that that is their way of protecting themselves. Just thought I'll share that.
No, I appreciate that. And that's like a lot of information you get from experience, not while studying. but but the other thing, like what we mean by disorganization is is basically when we're thinking, even when all of us are talking right now, we have a certain order that we're following. In
Mhm.
schizophrenia, it's just not a linear pattern. So sometimes their sentences won't make sense. They might even like make up a new word. Um, and then next is negative symptoms, which is usually, unfortunately, the hardest one to treat. Um,
Mhm.
and diminished expressions is basically if you've heard the term like this person is checked out, like they just don't seem present in the moment. And that's exactly what we mean by diminished expressions. So they don't have interest. They don't. They could be very asocial, and being asocial could lead them to have problems with their hygiene. Like they might not shower. Like there's a lot of problems that can go on with it. But those are the negative symptoms. We briefly
And
touched up. Oh yes,
can
go
I
ahead. Sorry.
Can I join in
Yeah,
here? And when you're
hundred
talking about
percent.
negative symptoms too, especially when you're talking about diminished expression, I think one of the caricatures that we usually see is the lack of emotional expression, where there's a failure to respond to environmental stimuli. So we could be having a conversation and it should elicit a emotional response. There should be surprise or fear or something, but we're not seeing that reaction. And I think that's a common symptom that persons look to. And when we're talking about diminished expression, it also includes diminished physical expression. So we're not seeing the motor movement that is very common to our interaction. Like we're people who use our hands, or even when we're sitting, we occasionally shift our position, and that's not always present with people who are experiencing schizophrenia. There's often this motor rigidity that becomes challenging.
Yeah. Yeah. I'm glad you shared that with regards to the diminished expression, Janvi and Tia, because that is very significant. Nicole M asks a wonderful question. Nicole M asks, why is there a delineation between positive and negative symptoms?
Which of
Yes.
us want to take this one? I guess I will get started, and John, I
Okay.
invite you to join in. Sure.
Yeah.
Yeah,
So
sure.
it helps us in organizing and identifying what the symptoms are. So when we're talking about positive symptoms, we're not saying that they're good things. We're saying that they are additions to our normal expression or normal experience. So hallucinations are additions to our sensory experience, or delusions are additions or exacerbations of existing thought processes. Now, when we're talking about negative symptoms, we're talking about reductions or removals of what is expected to be normal expression or normal
Mhm.
behavior. So, reduce social interaction, reduce expression, reduce motor activity.
Mhm.
I
Does
think
that answer your
you
question,
yeah,
Nicole? So,
that's perfect.
it's almost like if you, in adding to what Tia shared, is can you see it or not? So, with the positive symptoms, as a clinician, I can see it, right? And this person is actually their motor. They're showing their fine and gross motor skills. But when they're in the negative symptoms, they have, they're apathetic. So they have dissociated. So it's almost like a blank slate. So you see them just sitting like this, almost like catatonic, right? And they're not moving. They're probably blinked. You would leave in the morning to go to work, come home, and they're sitting in the exact same spot. They haven't moved. You ask them, how you doing? What's wrong? There's no answer. Or maybe fine. And it's almost as though this person has disconnected from themselves. Thank you for asking that. Yeah. Okay. So, John V,
Yes.
take it away.
Yes. Thanks, Nicole. She's also my high school friend. So hi, Nicole.
Oh.
um, I appreciate the question. So yes, we kind of touched on cognitive impairment a little bit earlier, but basically it's what we were talking about. It's just lower processing speed for things. Their memory, like their ability to make memories, is a lot lower. Their attention is lower. A lot of things are lower. And then because of all these symptoms, it can get confusing, even with our organization for all of it. So in science, luckily, there is a method to all the madness. So there's an algorithm for us that makes our lives easier. So first, what we want to do is we want to separate between a mood disorder or like a psychotic break. So if you see more emphasis on mood, which is like depression or those kinds of problems, then obviously you go down that algorithm. But if it's no, we're going down on the right side. And now you're going to ask yourself the symptoms that we discussed earlier. Do they last more than 1 month? If the answer is no, then it's a brief psychotic disorder. And if it's a yes, then we move further down the algorithm. And um, also, again, all the symptoms that we discussed, now we're discussing the severity of them. So this is to distinguish between delusional disorder. So if you have lots of hallucinations and stuff, you're going to say no on this side and then keep progressing down. And now the final thing to ask is, after you've after you know that you've had these symptoms for more than 1 month, they are pretty severe. Do these symptoms progress for 6 months and there is no real remission to them? That's how you diagnose schizophrenia.
Okay. Thank you for sharing that, John V. And
Of course.
so we are going to move on to Mythbusters. All right. So, Tia, take it away.
Yes, because there are a lot of myths out there about schizophrenia. And number one is is schizophrenia causes violence, and I think this is probably the biggest one that's perpetrated by the media and um general conversation. But violence is not a behavior that's seen in all people who are experiencing schizophrenia. And for those who do perform violent acts, we find that there's actually a history of that, whether it be in their childhood or even instances of substance abuse that are that's contributing to that violent behavior. So it may not necessarily be the schizophrenia diagnosis that's causing that violence. However, because we see that overlap, it can be confusing. However, the sad thing is persons who are experiencing schizophrenia are more likely to be victims of violence by other members in society.
Mhm.
So,
Yeah, and so that goes back to what Javi said as it relates to how do you diagnose someone, right? And so if a patient comes to the hospital, or let's say a patient is referred to me from the hospital and is being discharged, and they share with me that they had took an edible and that they began to see things and images, and they were diagnosed with schizophrenia, I would send them back to a different psychologist or psychiatrist. I would actually send them to a psychologist to rule that out, because substance induced or hallucination is not an indicator, a definitive indicator that someone has schizophrenia. And a lot of times people misinterpret that. I think also we're going to get into another myth that I want to talk about, but I definitely wanted to jump in and share that here. Yes, Tia?
Absolutely. So when we talk about myth number two, this is a big one as well. Schizophrenia means that you have a split personality. When actually schizophrenia is not a split in personality. And I think that confusion comes from how the word is constructed. Schizo meaning split, schizophrenia meaning mind. So it's a split of the mind. But that doesn't mean that they're two different personalities or multiple personalities coming from that split mind. That's a different diagnosis that we know as dissociative identity disorder that we can talk about at another time. However, schizophrenia is better understood as a break from reality, and that takes us back to the understanding of hallucinations and delusions, the fact that these things are not real, but it's very difficult to distinguish between what's real and what our mind is creating, our mind is telling us. So no.
Mhm.
And then we go on to our next myth, that persons with schizophrenia cannot recover. And that is not true. And the research is there to show that. And in fact, about 50% of persons who have been diagnosed with schizophrenia experience recovery. Some recover to the point of not experience any psychotic symptoms later down, and others they may experience symptoms later down, but their functioning has returned to almost normal. And even beyond that other 50% that doesn't fully recover, there is still about 25% who can still continue to function but require additional support. So yes, there are some people who may not recover, and I believe that's the case with most illnesses, physical and psychological illnesses. However, for the vast majority, there is opportunity to recover with the correct treatment.
Absolutely.
And we go to our fourth myth, and this comes right, right aptly after the last myth. People with, if you have schizophrenia, you will never hold a job. And that image is often very much portrayed as,
Mhm.
we see persons with schizophrenia, we think that they are living on the street, or they're living in the hospital, and that is not necessarily the case. Most people, once their symptoms have been managed with the appropriate treatment, and John is going to be talking about that treatment in a bit, they are able to maintain their jobs, and their jobs can be in a variety of fields, in business, in creative arts, in hands-on fields. There are so many things that can be done, and many even go on to achieve various educational and personal pursuits and live fulfilling lives with families and wonderful relationships.
Mhm. Mhm. When we talk about myths, I just want to stay here for a few minutes, because so there's two sides to it, right? So we have, sorry, Dad, if you're watching. So I remember when I was really young, and I think that still holds true today. And he would tell me these stories, in Antigua about Jumbi and all of that. And I'm not saying in any way I do not believe in the spiritual life. I am not saying that, because I do. So anyone can say I'm crazy. So that's fine. And I don't use the word crazy. But I remember him saying that this woman um, was speaking another voice, and that, they came to do like an exorcism, if you will, to draw the demon out of her. And when I got older, I said, "Daddy, you remember you told me that?" I said, "I think she had a mental illness. She had a she was having psychosis. I said, I don't think that was a demon. But I remember hearing quite a few stories like that, right? And the reason why I say that, because sometimes people will reference to mental illness like a demon, or they will reference it to it like something demonic, but it's actually a mental illness. It is not someone who necessarily is possessed. And there's still a myth that this person is possessed, or someone put a curse on them, put something on them, or that time when someone they went into their house or something like that. It is a mental illness. I'm not discounting spirituality or religion. What I'm saying is, most of the time, it is mental illness. And there's another piece to that that doesn't necessarily fall underneath the myth, but also ties into how, when our ancestors were slaves, it was weaponized against them. And there was a mental illness that then had sort of mimic schizophrenia. So I'll read it to you. So the diagnosis, it was drapetomania, or the disease causing, quote unquote, Negroes to run away, right? Although it is unknown to our medical authorities, although its diagnostic system, the absconding from service, is well known to our planters and overseers. This was written by the Dr. Cartwright. So he's the one that had created this disease, and labeled it in a way that they would then put them in asylum and sort of put them, away, right? So it goes on to say, in noticing a disease not heretofore classed among the long list of maladies that man is subject to, it was necessary to have a new term to express it. Cause in the most of cases that induces the Negro to run away from service is as much a disease of the mind as any other species of mental alienation, and much more curable as a general rule. With the advantages of proper medical advice strictly followed, this troublesome practice that many Negroes have of running away can be almost entirely prevented, although the slaves be located on the borders of a free state within a stone's throw away from abolitionists. So it was a way to say that, them seeking freedom was that they were mentally ill, and basically schizophrenia, right? Because that was someone who had the splitting of the mind, and it was horrible. So what I read to you is not a fact. It was actually written by a supposed psychologist, if you will, and it was spread. This thing was written, is a very long, and I'll put it in the chat, is by PBS. Anyone that lives in New York, you know what PBS is. And this write up is telling as to many of the reasons why a lot of Black people, and perhaps even Black Antigua and Barbudans, have the stigma surrounding mental illness, because it was, in fact, utilized against us in a way that led many of our ancestors to hush and not say anything, right? So even if someone did, in fact, have a mental illness, you dare not say that, because the cost of it was you were placed in a horrible asylum, or most importantly, you were killed, right? So when I am engaging with clients and patients, and particularly in certain regions, Black and brown people, and Black people in particular, I am always keeping this in the back of my mind. When we talk about stigmas, we need to understand where it came from, because there is evidence that our ancestors prior to this were very much aware of mental illness. It wasn't phrased as mental illness, but they would use herbs. And for those that were psychotic, they would place them on the tree, and you can Google it and look it up. They would place the medicine on a tree and they would put them in an area, and they would take these things from the tree that was medicinal to help them with stabilizing their minds. And so I share that because the stigmas most often is a result of trauma, right? And so it just got passed down from generation to generation. And but in knowing that ancestors before were aware of that, that knowing that we do have the ability to re-engage with mental health care in a way that we understand it was something that was known centuries ago, and that is not a new thing and is not some Western thing that we're trying to impose. And so I just had to share that because I just felt that it was very important, when we talk about stigmas and when we talk about myths, that we have some comprehensive understanding of where it's rooted in. Yeah. Anyone wants to add anything?
I just went through a lot of emotions. It went from anger to like a little wholesomeness with at the end with people helping their community out. But I think the anger comes from just lack of abuse, like not lack, it's the actual abuse of power, because they're supposed to be the knowledgeable people when they diagnose people. So I think it's not just about being knowledgeable. You have to be a good person. You have to see an individual, like the way you view the world as a healthcare professional matters. And that is a clear, good example of that. Like you could ace your exams, you could do really well. But if you're not a good person and you're not able to see a person as a person, it's means nothing. It actually doesn't.
Absolutely. And I appreciate you sharing that. But also not doing the research. For me, it's
Yes.
not enough for me to just say that persons are holding on to myths and stigmas because they don't want to do anything better. For me, I need to research, well, if we know the history of some of these diagnoses, we need to know the history of these diagnoses in this community, in this
Hmm.
country, and understand where is the fear, right? Where is this generalized fear or generalized anxiety disorder, anxiety? Where is it coming from that creates sort of and I don't want to use the word difficult, but it can be difficult, right, to engage the families and get them in a way to accept it, right? And it's really about understanding where it comes from in terms of trust and how we're engaging them. And so if we're in the clinics and we're in the hospitals and they're not accepting, are we, oh, you don't want any help, or is that the response that we're having? I'm not saying that's the case, but I worked many years in a hospital. So as a social worker, I've seen it and I had to intervene, and I had to let the physicians know, or the nurses, or the therapist, the rehab therapist. I'm like, let's reconvene and let's re-engage with this family because that's not helping. Right? But not everyone has a social worker that's able to identify that or the wherewithal to do that. And so I think it's just really important when we're talking about compassionate care, when we're talking about myths, that we do have an understanding where it comes from. I'm off my soapbox. All right.
And I just want to add a final piece here. And I think that's why it's so important for us to have these conversations so that the knowledge doesn't stay with us. It doesn't just stay with the practitioner. But while we're exploring the history behind it, we're able to share this with the community in addition to the facts of what actually is happening so that the community can also feel empowered. And that's how we continue to do the work of um, breaking down these stereotypes and reducing the stigma that we're experiencing here.
I think that is like the perfect segue to the next part because I think once you talk about the stigmas and myths, and everyone is well educated, whoever is important in the treatment process, it really helps. I, I think it's really interesting to see, especially with schizophrenia, we've touched on the myths already, but I'm really glad that lately we've been talking more about mental health. Depression has been more knowledgeable for people, like people know more about anxiety. But I think when people, even suicides, like people are more compassionate of people who are suicidal, like they will get them help. But I think people are still a little scared of people going through a psychotic episode. Um, so I hope with this presentation, they don't have to be the first person to help out if they see it happening, but at least not run away from them. Call the right people, whatever you need to do to get them help because they need help. They can't be ignored. Um, so, patient education is definitely the first thing that we want to do when they come to us. Because if they're well educated, they can educate people around them better. And this can help us with their appropriate treatment management. So, when we do treatment, we basically have certain objectives that we want to achieve. So, number one objective is minimizing the symptoms, and the symptoms we already talked about a lot. Um, so, how we do that is first line is antipsychotics, and then if they have any comorbid psychiatric disorders, we treat those as well. The second objective is you want to minimize the side effects. So you gave them the drug, now they have side effects. As you can see at the bottom, it says when they take oral medications, the adherence rate is about 60%. And the reason for that is because of the side effects. They don't like the side effects, they don't like how it makes them feel, so they go off it. Luckily, because of new research and more scientists and healthcare professionals putting more work into this, they've thought of a long acting injectable. Long acting just means that it stays in your system longer. So you have to administer it less. And this helps with relapse. So the patient is more likely to stay on these medications, and then that's why they don't have relapse. And then, which is the third objective, which is avoiding relapse. And because when you relapse, obviously it's not the end of the world. You start the system again. You start the system, like you go through the process over and over again as needed. But with a good support system and good care for that patient, you can achieve the last objective, which is promoting their recovery stage. And this is depends where you live. There's lots of things available like group homes. You could have your own support system. Um, and by educating all of them at the end, the goal for that patient is so they can pursue their own personal goals and they can finally live a normal life. And we've already discussed in the midst that this is totally possible. They can live normal lives um, with the right treatment and right method to it. And I hope that was helpful.
Thank you.
Okay.
T, I don't know if there's anything you want to add as it pertains to medication.
Uh, I think the biggest piece that Jahnavi spoke to is the need for adherence, and I think that's the biggest challenge. And while you're talking about medication management is really important for persons who are experiencing schizophrenia and their support systems to remain in communication with your doctor, and not just with your doctor, but other professionals who are in your circle of care, because the ultimate goal is to enhance and support functioning. And if you're having a reaction that's not helpful, or if someone around you is having a reaction that's not helpful, that is the time to reconnect with your physician, share what's happening with your physician, so that whatever adjustments or whatever accommodations can be made can be done. But sadly, we do have the aversion of doctors that, as I believe, would have stemmed from what Serene would have shared. And the option and the decision often is to stop medication or just come off of it or make our own adjustments, which usually ends up with reactions that we're not hoping for. So
Mhm.
maintain that relationship with your team of care. And I intentionally said team of care because while you're working with your doctor, you also have your psychologists and social workers and your support team at home or in the community that's a part of that as well.
Mhm. Thank you for that. Nicole had asked, do long-acting injections have less severe side effects? Um,
Um,
and so, someone wants to answer, or
I can say something, but then if you want to add onto it,
no?
feel free to. So I think every person is slightly different in how they are affected by each drug. So it is person to person. Um, but a lot of I think the long adherence is like the the difference in the beneficial, like why long acting is better is because they don't forget to take it basically. So with oral medications, I think side effects really vary based on person to person. But the reason why oral versus long acting is better is because they can actually take it. They will, because it will be administered by either like their doctor or something like that.
Yeah,
And
yeah. I don't.
I've been to like clinics in Antigua, and I was at a psychiatry rotation. The patients that came in were schizophrenic patients, and all they were coming in to do was just put injections in for their routine treatment. But go ahead.
Yeah, no, I don't know. I don't have any studies in front of me with regards to the IMs, the injectable medications being having less severe side effects. And as you mentioned, John B, all medications have their own side effects and persons react differently to medications, unfortunately. Yeah, and you know, I am, if it's safe, I am a big proponent. I'm a big advocate for injectable medications for persons with psychotic disorders because of the unfortunate um, disconnect from reality that comes with it. A lot of times there is, and oftentimes, there is an expression of, there's nothing wrong with me. I'm perfectly
Mhm.
fine. It's everyone else, right? Because their brains are not allowing them to be aware of reality, and it's a protector, right, for them. So you telling them that they need to take medication, their brain is like, oh, look, here it is now. This is proof that they're trying to harm you. And so then therefore there's a higher risk for persons with early diagnosis, I would say, of schizophrenia and not untreated, to not take their medication. And so I'm just really supporting what you mentioned, John B. So that takes us to living with schizophrenia. And so I wanted to share a few videos, two videos, as a matter of fact, of persons who are living successful and happy and healing lives. And they will share with you briefly about their experience and where they are in this life today. So let me just share my screen. Let's see here. And let me know if you all can see it. All right.
In the beginning, I try to rationalize the symptoms of having schizophrenia, like hearing the voices. I would think that they're coming from my cell phone or the people around me. And sometimes I heard one voice, other times I heard multiple voices. They told me I was dishonored to my family.
I can't see the video.
The symptoms got progressively worse during my years
Okay.
Okay,
in
So,
college.
perfect.
all right. Sorry, everyone. I am going to have
I
to
try to rationalize.
do it over. Ready?
Yes.
All right.
In the beginning, I try to rationalize the symptoms of having schizophrenia, like hearing the voices. I would think that they were coming from my cell phone or the people around me. Sometimes I heard one voice, other times I heard multiple voices. They told me I was dishonored to my family. The symptoms got progressively worse during my years in college. Eventually, I just couldn't handle it anymore. I lost interest in school. I couldn't focus on my classwork or my assignments, and I dropped out of school. I learned of my diagnosis through an unfortunate crime I committed while experiencing psychosis. I was very confused and afraid at the time. I'd actually stolen a military truck from the airport and was arrested for that crime. While in jail, I stopped eating, drinking, speaking, living. The symptoms got progressively worse, and they didn't know what was wrong with me at first. Initially, I did not know that I had schizophrenia, so I refused to take the medication. I was in denial. I didn't have any insight. While I was in jail and I wasn't cooperating with my attorney, they had me take a competency test, which I failed. Later on, I got committed to a state hospital where they diagnosed me. I'm able to talk about it now because it's in the past, and I know that I've survived it, and I'm coping with it and continuously working on my recovery. And I talk about it a lot just to share my story with other people so that they know that they can recover as well. Society views schizophrenia as a person having split personality or a person who is extremely violent or dangerous. Those stereotypes really bother me because I don't look at myself as a violent person. I don't have a split personality.
Okay. Any comments about that? All right. So now I'm going to share with you another individual who shares their story as well. Let's see here.
I started hearing voices, and it was not unfamiliar voices. It was mostly characterized voices of my friends. I started getting really paranoid because obviously the voices were saying things that disturbed me. Really and truly, my first break came about when I was 17 years old.
My son has been an adventure. You never know ahead of time where the challenges are going to be in life.
I'd been trying to get people to realize that there was something going on with me that wasn't quite normal, and wound up getting into trouble. I was checked into an adolescent rehab center, so to speak, and was put on medication there, and that was when I received my first diagnosis. He diagnosed me with paranoid schizophrenia. Stopped taking my medication after about a year. It didn't take very long for my symptoms to start returning. I thought, if I don't do something, to get some help, I'm gonna end up, dying or something. So I walked past a fire truck. I saw, an axe on it, and I thought, well, I'll just take that axe off that truck, and someone will have to notice me then. I didn't realize it then, but that was the beginning of several years of it being in an institution.
It's not a book written to tell you how and what to do as a dad or a mom. For me, the lesson I have learned is that I don't have all the answers.
Sharing my story is a privilege, and it's important for me because it reinforces my recovery, my life. It helps me stand on my own 2 feet every time I share it.
Okay. So, people, what did we think about that? Yes, Pamela, very interesting. And we want you all to offer some feedback. Yeah, I believe those two videos show distinctly that persons diagnosed with schizophrenia, once you receive the care, that you can live successful lives. But I would be remiss in not sharing the distinct differences in their experience. Did anyone realize the difference in their experience when they both had a psychotic episode?
Well, thank you for commenting on that. But what I noticed was the first person who looked very much like us was um brought through the legal system, while
Mhm.
the other person who doesn't look like us was taken directly to medical care.
Yeah, absolutely. You know, and that's a lot of times what happens. As someone that lives in New York, we oftentimes see persons who have a mental illness or oftentimes criminalized, who are incarcerated for long periods of time, who are showing um, that they are having difficulties with their perception and reality, who's showing hallucinations and delusions, who are somewhat incoherent in some ways. And it's unfortunate, right? And it's telling to the experience, because this woman was incarcerated, or at the time was a young lady or teenager, was incarcerated for some time and was even given a lawyer, and clearly, and although I'm sure she was saying, "I don't need a," that sort of thing. And and I don't know if how much her family is involved or not, but they show completely distinct different situations. And what's ironic about it is that they both had stole a truck, and one was sent to jail and one was sent to rehabilitation. And they both share that that was their breaking point, that is when they realized they had schizophrenia. And so, for me, as a clinician, and I share with Jahnavi, as we spoke before and talking about what we're doing in this webinar, that is so important. When you're delivering from a holistic approach, you also want to be culturally affirming, right? And understanding that. And so when we're talking about persons in Antigua and Barbuda, and where Antigua and Barbuda is at, and making steps and progress in mental health care, you want to keep that in mind. How am I engaging with this patient? Am I engaging with them, me knowing what schizophrenia will tell them and their perception of this experience? So I don't know if anyone wants to share anything.
I can say in my experience, it really all just comes back down to education and being compassionate, and not just the diagnosis, but what does having to undergo treatment mean for that person? What does having to go through the gates of that hospital mean for that person, mean for their family? And how do you negotiate it? How do you negotiate with them and the family in addressing that? And I think that's something that we really do need to paying attention to and work on. And I think that really comes out of building relationship with our clients. I know that our capacity to do that may vary based on um, our how how we present with our clients in our initial sessions, or at what phase of psychosis they may be in when we encounter them. But we do have to hold space for that. And
And I was
how
just saying, absolutely.
yeah,
Hmm.
and help families, even if the client is not in a position to make that clear judgment, help families to understand that and cope with what that means, because that they also have to return to society and they have to reconcile that within themselves. And often there's a belief that they may have failed in some way, because a member of their family is experiencing a psychosis, and that is not it. And helping them to process those thoughts is very important.
Absolutely. Yes, Tia. Thank you.
Yes.
Nicole shares, really generous of them to share their stories. It is, right? How courageous is that to be open about um, their lives and their experiences in living and managing schizophrenia. Pamela Farrell, hi, Pamela. She says, you must take your medication once you have been diagnosed with schizophrenia. Yes. John V., do you want to answer that fully for Pamela?
Okay. We're not hearing John V very clearly.
Oh, no.
Sorry, it's raining a lot here, so I just muted myself in case you could hear it. But yes, I think first line of treatment, as I mentioned, is antipsychotics. After obviously patient education and all of that, it is the best way to treat the symptoms that we mentioned. And then you, the provider, the healthcare provider for that patient will reassess based on how their specific patient is reacting to those medications.
Thank you for asking that, Pamela. Did we answer your question? Feel free to ask more. Thank you. No, Nicole said the woman was convicted. She was answering my question. Yeah. How unfortunate is that? So that brings us to a closing. John V., we want to express gratitude, nothing but gratitude to you for joining with us. And we hope that this will be one of many live webinars, free live webinars that we can share for Antigua and Barbuda. Persons are watching from all over, as a matter of fact. Um, I have my family watching in the US and in Antigua and Barbuda. I don't know about you,
We have
but
Canadians watching as well because I'm from Canada.
oh, okay. I didn't know that.
Yeah.
Okay, awesome. And so this live is recorded. It will appear on both the Antigua and Barbuda Holistic Coalition Facebook page as well as my YouTube page. In regards to that. Oh, Nicole has some more information. All right, Nicole, come in. So, Nicole says, is there research reflecting the impacts of having a doctor who is from your community being part of your medical team when one has schizophrenia? Um, so, Tia, you last, so I'm going to let you answer that.
Uh, I'm not exactly sure about research as it pertains to recovery rates, but I would like to believe that there's greater levels of adherence because we're working with you at a level from a place that you understand and that respects your experience as an individual. And if we're able to communicate and create that understanding, then it's easier for us to work together in a healthy manner, and there's more collaboration in that way.
So, Nicole, so I am born in the US. And my family, my parents were born and raised in Antigua and Barbuda, and all my siblings. I'm the youngest of four. I don't know if you heard that part. Um, so I have some familiarity with the culture, but there's some ways that I do not. Like there's some terms and dialect that I'm unfamiliar with. One, when my family migrated here, they were very much, um, how do I say without getting in trouble? Because my mom is gonna be like, they were very much about you have to talk English. So my siblings, they had to talk English. Speaking the dialect was unheard of. Um, I know that we're moving away from that. I'm hoping, but there was the accent had kind of it faded away. So my ears, although I went to Antigua every year, I believe, and it's true that most persons would what we say yank. So when I was around, they would like yank around me because I was American and they, you know, and so I didn't learn a lot of the dialect or the terms that are used. So someone can say something to me, but not understand what I'm gonna say, you know, I would have to like pick up on it and like, oh, that's what I think they're trying to say, and sometimes I wouldn't. And the reason why I'm sharing that with you because as a clinician, right, I believe that it can be bittersweet. I believe persons engage with me because I don't have that strong connection, so to speak, to Antigua Barbuda, so they feel safe in sharing information with me, whereas other persons will view me as an outsider and feel as though that I'm not able to offer them the support that they need. And those persons more so, I'm not poo-pooing on anyone, I'm just keeping it 100 if you know me, are professionals, are practitioners who may say, "Well, Serene is not from Antigua, so she doesn't understand." But as Tia mentioned, as long as you are mindful and intentional about it, I do believe you do, and I agree with you, Nicole, that there needs to be more Black and brown, um, women practitioners welcomed into the facilities in Antigua and Barbuda, and there needs to be there needs to be jobs created for that. Um, because when you're looking at from holistic point of view, physicians should be aware about hormones, right? So when I'm engaging with my clients, I may not be from Antigua and Barbuda, but I'm going to ask you, you know, depending on your age, does your family have early onset of menopause, menstruation, thyroid, diabetes, anything that can impact or influence your mood aside from a mental health condition stemming from trauma, genetics, etc. And so that in itself allows a person to feel seen and heard. And that is very valuable. And so I believe that yes, a person from the community who is a practitioner is very helpful because then they may have an understanding of the region that they're from. And so, what some people do not understand is that my family's from Willikers, so we're from the country, right? And then you can be from Sweets, where Tia is, and there's certain dialects that we have that are not the same. There's certain practices that we have that are not the same. And if you're not from Antigua, you may not know that. So your clinic may be very much maybe your clinic is in Suites and then you go to Willikers and your interaction with people in Willikers is the same. And maybe there needs to be a little variation. Tia, take it away. Correct me where I'm wrong. I'm all
No,
for it.
that's absolutely true. And we do need to recognize that culture is not just national culture or even racial ethnicity, because we each have our variations. And even if we're from the same village, there we're from different households. We have different life experiences. So cultural competency needs to get to that level. When we're working with people, we're working with individuals. We're not working with a label or a group or a strata.
Mhm.
And we must tailor to that individual's experience and be willing to learn their story from from where they intersect.
And before I get over my soapbox, while we're on that, when we talk about religion and schizophrenia, the persons need to understand the religious aspect that Antigua and Barbuda is very much faith based. And so you may have clients or patients who share that, well, I heard God tell me. That does not mean that they're hallucinating. That is their relationship with God, with their spirituality, in which the way in which they engage. And so that tends to be said a lot more than less. And I think sometimes people may think like, oh, I wonder, if they have, or they may say, well, I had a dream and someone pulled my foot, right? So um I'm not discounting it, but a lot of times those are what are lucid dreams. And I would educate clients about what are lucid dreams, um, and how dreams can present, how mental illness or mental health conditions can present themselves in sleep, and how the brain is putting together real real things that happen and things that didn't happen, because it's firing up, right? So, clients be like, oh, and I know something's going to happen and this bad thing's going to happen. And I'm like, this is an indicator. I said, now we have to find out if this is your anxiety disorder or if this is a spiritual thing that's happening. And so, not like diagnosing everything that the person says because they're speaking spiritually. And so I just had to share that. That's really important when you talk about cultural competence. So, Nicole, I'm very happy that you brought that up. Thank you, thank you, thank you. Pamela says she's from Trinidad and Tobago. Hey, okay.
Hey.
I have students from Trinidad and Tobago, UE, St. Augustine. I don't know if they're watching, um, but we have a few interns from UE, St. Augustine, and Trinidad. Yeah, so Johnny, thank you again. Thank you,
Thank
thank
you
you,
so
thank
much for
you.
having me. This was very insightful in all aspects, and I loved all the interactions with the viewers too. Thank you
Yes,
so much for having me. It's been a pleasure.
thank you so much.
Thank you, John B.
Yes. So this ends our live for today. Please follow us on Facebook.